Rotary Fellowship of Health Professionals. And this year, WHO, the World Health Organization, is tackling a very large problem of patient safety, which is lacking in many of our healthcare systems. And so this whole project is about educating people and educating people who are, including Rotarians who are writing grants, to be sure that we are doing these in a way that are helpful, and particularly in low and middle income countries. That's what the LMIC stands for, low and middle income countries. Not only do we want healthcare everywhere and for everyone, the vision for the World Health Organization and for all of us is that we would have safe, harm-free, respectful care everywhere, every time. This is the vision. Visions are designed to be usually higher than we can attain, but we begin with the vision. WHO has come out with an action plan that has 7 guiding principles in it. This will be part of an earlier presentation for those in a series of presentations on this topic. So the part of this is to engage the family and patients and the family as partners. We work together collaboratively with other organizations, with governments, with shareholders. That includes Rotarians who are writing grants. We analyze and share data. So that means it has to be collected. We create actionable and measurable improvement. We adapt policies and action to care and to create good action in the care setting. And we use both scientific principles as well as those experiences from the patient. And in all ways, in everything we do, we want to instill safety into the culture, in the design and the delivery of healthcare. So this is 7 specific strategic objectives from the World Health Organization. So it has to do with different areas of working, from policies, from the reliability of the systems, individual clinical processes. If you go in for a procedure, that these are safe procedures, that we are engaging patients and families. And if you know, that's fairly new in the healthcare system where that's happening. And that we include good health worker education, skills, and safety, and train them in this. And that we encompass the information, the research, risk management into this, and we create synergies, partnership, and solidarity with other organizations. There are additional burdens in conflict zones, and since much of my work has occurred in South Sudan, we've seen a lot of that in the news, and a whole scorched earth approach to a weapon of war, where they just go in and burn down whole villages, where they use rape as a method of war tactic, where clinics and health workers are attacked. There's a very high injury rate and even killing of health workers in various places. Clinics overrun. Doctors Without Borders have their clinics overrun in South Sudan. And included in this conflict is this displacement of people, the refugees that are going to other countries. Kenya, for instance, has over 400,000 in one refugee camp. Not only are people displaced, they lose all of their possessions. And even if they get back home, they may find that there's nothing left there. In addition to that, you end up with the military conscripting teachers and children to go to war, boys and girls. And to take teachers is a real tragedy because there's so much need for education. And finally, HIV in the soldiers, where they go, they spread the disease. And many, many people in the developing world have had TB that may be suppressed, and yet with the HIV, it gets activated. So now there's a lot of TB. And the global burden is in low and middle income countries. These are the countries that have the fewest resources, and they have seemingly the worst health problems. One of the very great indicators of how poor a system is how high the maternal and the neonatal, the infant child mortality rate is. In some countries like Scandinavia, Sweden, Denmark, obstetricians may have never seen a woman die in delivery and pregnancy. And yet in a country like South Sudan, at one time, the estimated rate of maternal deaths was over 2,000. Now I believe per 100,000. Now I think the latest measurement is 750 per 100,000. Compare that to a country like Sweden or Denmark, where you could count all of them on one hand. The difference between that's the disparity in healthcare between a very low income country and a very high one. There's also very high malaria and diarrheal diseases, very low education, low gender equality, so that boys are much more likely to be educated than girls are. We find that in high income countries, perhaps as many as 1 in 10 patients is harmed by their care. 1 in 10 encounters may be the wrong medicine, may be the wrong dose, may be the wrong frequency of taking it. Over the years, we've gone to having people, if they're going to surgery, having the patient mark which arm it is, which leg, which eye is going to receive surgery because of those mistakes that occur in the operating room. But it's not just in the hospital. In fact, more than half of the errors occur in the primary care setting. And in fact, there are estimated to be 3 million deaths each year due to unsafe care. 60% of deaths due to unsafe and poor quality care could be prevented with proper interventions. So they are preventable. Somewhere between 1.4 to 1.6 trillion US dollars is lost in productivity. But the bottom line is the fewest resources are occurring where the most need exists. Some of the common gaps in the healthcare system includes the numbers and levels of professional staff. Whenever South Sudan was coming out of war, I was working with the chief nurse there, who said that in all of South Sudan, there were 8 midwives. 8 midwives in the whole country. These are trained midwives. And that is the #1 criteria for reducing maternal mortality, is to have women deliver under the care of a trained midwife or other trained professional in doing deliveries. There's gaps in opportunities for clinical updates. There's gaps in the numbers of professional training programs. And often these training programs are not, they're run by nonprofits that come in and they may have their own criteria. We were evaluating a training program there to increase the number of midwives. They started off immediately saying, they need to deliver 50 babies. And then they quickly realized, well, we're not going to be able to get that many deliveries. So they just arbitrarily cut it to 25. And then as we got into the programs and looked at what happened, some of them were leaving the program, allegedly graduating, but they'd only attended 8 deliveries. And so they really hadn't developed the competency to be able to do what they were trained to do. When we asked, but why did you graduate them? They said, but the funding ran out for the training program. So it wasn't that they couldn't hold them over, but they didn't set up something to really account for that. They're often lacking in the necessary equipment, supplies, medicine, treatment options. There may be tremendous distances from these various places. The communications, they often have no way to be able to connect with another setting. Transportation may be a problem. People will often delay going, and then budgets. In fact, when I was at the Juba Teaching Hospital, I was talking to the administrator there, and he said, but how can I administer? He said, I don't have a budget. So I would think one of the take-homes from that is when you are maybe thinking about doing a Rotary grant and someone says, well, this is for this country's teaching hospital. In our minds, we often have something that's comparable to something that we know, and that isn't necessarily the situation in another country, particularly a low-income country. Some of the challenges that patients face is the cost of care. They may not be able to afford it, or they may be required to bring medicine, supplies, and candies and gifts to the hospital. In one of the hospitals where we had nurse midwife students, we found that they had very few women who wanted to come in to deliver there. And so there were a lot of reasons for that. So we got into it. Why? Well, you had to bring your medicine, you had to go to the pharmacy, get the medicines they needed for the delivery, you needed to bring any of the supplies, and a lot of times there were requirements where you need to bring gifts or candies or treats for the staff. The distance to the nearest care facility can be a problem. At one point in South Sudan, only a quarter of the people had access to any form of care. So the kind of high-level care that you might need for emergency situations would often be just not even attainable to people. Then there's often poor provider-patient communication. Many women have said, well, they don't like to go to the hospital because they don't like the way that they are treated there. So they may have distrust of the healthcare services or the whole system. And there may be cultural beliefs about this. There supposedly is a belief in South Sudan that women are more of a woman if they deliver at home and alone. And I wonder if that's really, if that's something that's come over time because it's so difficult to go anywhere. Many people deliver either with their family or with an untrained midwife, but they've had no training, and so they're lay. And they may require gifts for the delivery. One of the problems that comes up is a mythology that if the woman stalls in labor, which is not unusual, and they generally then need a C-section, a surgical intervention, but there's a mythology that if a woman stalls into labor, it's because she's had an affair with someone. And if she doesn't name who that person is, and she's not going to progress in labor. So in desperation, some of these poor women are naming someone, which creates one problem if they survive the delivery. But you know, these cultural beliefs can really be an impact in this and lead them to not get transferred in time to a higher level of care. 94% of all maternal deaths occur in low and middle income countries. And there's a picture at the right that's very difficult to see. And the hand that you see at the left is a syringe. It has some baby formula in it that is being given to this newborn. To the right and upper part are two elderly women, and these are the grandmothers. The mother of this newborn died in delivery. And so they brought this newborn to this clinic to see what help is available. Many women die because of hemorrhage, which is often treatable if the person has been trained. They sometimes die because of obstruction, because the birth canal is just not an adequate size. And here, some of this comes from early childbearing, child brides. Early childbearing is fairly common. Infection can be a problem where people really don't have a clean place and clean materials for delivering. They may be unassisted by skilled birth attendants. And often, as I mentioned, the delay to emergency care. Where do we focus care if we want to try to prevent some of these problems? And, you know, the first is what we know is that if people would avoid child marriage in those early childbearing, you could reduce maternal mortality by 30%. That would be huge. But that's a cultural thing, and that is also an education issue. What we know is that the higher educated people are, the more options they entertain, the more likely they are to forego having children early, and more likely to space their pregnancies. So putting a space of 2 years or more between pregnancies is very helpful. improving acceptance of delivering in hospitals and clinics, and that can be a lot of different things. Incentives to get people to come in would be helpful. Increasing the supply of skilled birth attendants. That was one of the approaches that we took in South Sudan, is they started a nursing and midwifery school in Juba. And now they've increased, my understanding is they've increased from 8 to 400 trained midwives now for the country. But a lot of this means bringing in people from other countries to be part of that training process. Providing emergency obstetrical care is much more difficult because you need these centers in various places, and trying to get professionals, high-level, well-trained professionals, to live and work in rural areas is a big challenge. And then making transportation to care available. Infant deaths tend to go along with high infant death rates, tend to go along with the high maternal mortality rate, and for some of the same reasons. Infection, sepsis, pneumonia, diarrheal diseases, tetanus. I'd never seen a case of tetanus in the United States, but saw a newborn with tetanus. Getting all of these mothers immunized before they get into childbearing. Measles is still a problem in much of the developing world, and malaria is an ongoing problem, particularly in sub-Saharan Africa. Birth asphyxia, patients, providers not being trained on how to resuscitate a baby, preterm deliveries, and malnutrition. Countries like South Sudan, many of our poor countries, malnutrition is a huge problem. In an earlier slide, we were talking about using data to be able to make decisions, but data challenges are huge. In this is a clinic that I've worked with in South Sudan. This is a mud hut. We referred to it to the rat hut because there were rats in there that liked to get up in the straw up above the desk. But this, in order to be able to record data so that it can be transmitted, this is a computer. So we have a setup for internet outside, which works sometimes. You have to have power, so you have to have solar. There's no other form of electricity here. And then you have to have eligible writing, which is a challenge here because many people were very malnourished when they were young and have neurological damage from that, and so have difficulty writing. The blue card is a medical record. So this is a medical record for Kala-Azar, visceral leishmaniasis, which is one of a very deadly neglected tropical disease for which we do not have a prevention. We don't have an immunization for this. We've tried, but haven't gotten there. But it is treatable, and this particular physician happens to be one of the world experts on treating visceral leishmaniasis, which is why she has the clinic in this particular area of South Sudan where periodic epidemics occur. And so she created this one card for tracking, and it makes it, it's immediately identifiable, collects all of the data for the daily visits because they may be there for 30 days or more to getting treated. It also has a record of the particular medications that they've received. And then there is another form that was created for the admission. So the whole set of medicines and diagnostic tests that were done to the person to get into the program. Some of the cultural beliefs, at the same time we were having an epidemic of this visceral leishmaniasis, some of the people from the government and other places came to let the community know that they cared about what was going on. And so they brought this cow for a cow sacrifice. So we can have a very high level, well-trained physician here who is delivering Western medicine care, but it's going alongside cultural beliefs that sacrificing a cow, and this cow had to urinate to show that it was healthy, and which it did perform that for us, and then it was sacrificed. And some people got a good meal, but it did not cure the epidemic that continued on after that. Another factor in healthcare there that we might not think of in the US is that people need food. For people to come in for TB treatment, they're going to be there for 6 months. There's no way they can bring in enough food to take care of themselves and whatever family comes with them for 6 months. So the World Food Program comes in with bags of sorghum and lentils and a little bit of sugar and some oil for people to feed. At one point, we were treating 1,000 patients a day. Now, this is the kind of thing that as a nursing faculty member would have driven nursing faculty straight up a wall, to see so many syringes pre-drawn with medication sitting out on a table underneath the trees. But this is how we treated 1,000 patients a day. And there were, I don't know, 5 or 6 setups like this scattered around the front yard under the trees. Of course, there's no formal blood bank out there. So what do? Even in the cities, there may be a blood bank, but there may not be blood in it because people may be very reluctant. So it's not unusual for those of us who are expats who go over to help to be asked if we would be willing to donate blood. I've done that many times there. Very often families don't understand. They are very fearful of blood, don't want other person's blood in them, don't want to give blood. I think a future project might be for Rotary clubs to organize blood drives in these countries and to encourage people within settings to be able to build up blood banks. One of the issues that came up, sometimes it's when you're working in the field, things will present themselves to tell you, well, what needs to be done next? Here we had a cow come into the patient area, and I laughed and said, well, this cow was trying to decide whether to get the bed by the window or the one that had the mattress on it. I'm not sure which one it decided, but the solution to this was to fence the hospital. And so that stopped us having that happen. This was another innovation that came up, and you see these little bags taped to the back of this metal cabinet. This was a intervention that came up after being part of early, I think it was within the first few days that I was in the village, and there was the medical emergency with a very small baby, and a particular medicine was needed, and the poor young health professional couldn't find the medicine. And so in the US, we would have a medicine cart where all of the medicines would be organized. You could quickly grab the right medicine syringe and give the medicine. Here, the easiest solution was to take a plastic Ziploc and put in not only the medicine, but the syringe and the needle so that everything is in one place. And then to label the other medicines so they're more easy to locate. This worked really well, only no one seemed to have the idea that once you used it, you should refill the bag. So that took another training to accomplish that. Equipment donations. We're very big on donating equipment, and these are 2 infant warmers, very sophisticated. You would find them in any very progressed country. The progressive countries would have these. They're also very expensive to operate. The nursing care that you need for this is a high level of care. And it's not just for these isolates, but you're also going to need IV fluids that are very carefully titrated for the very small babies. You're going to need oxygen. Well, this is in this teaching hospital that has inconsistent electric power, lacks consistent oxygen, does not have this highly trained nursing staff to be able to use these. And in the right hand isolate, you can even see that is somebody's very nice headscarf. So I'm not sure that these get used very much. But when people think about, well, high maternal mortality rates, they need isolates and high-level equipment. No, they don't. That isn't where you start. And that's one of the things that, as Rotarians writing grants, that we need to be cautious that the equipment that we send are usable there, that it's the right setting for that kind of equipment. In the end, a lot of health errors are due to limited education, either education of the individuals, of the patients. We talked about that being the more highly educated people will use birth control so that they're better able to space their births. They just have better health outcomes altogether. In this setting, this was the single school building for this whole village. And as you can see, it's not in very good repair. It wasn't even being used. Most of the classes, such as they were taking place under the trees. But there were very few teachers, and the teachers were often not in the classroom. They also had very few materials to use, and they had limited supervision, which meant they often weren't there. Very low pay, very low commitment, and huge gender gaps in education, so that a lot of girls are just not getting educated. Once they get particularly to the point where they start having their menses, many girls will just stop going to school altogether, either because family is concerned that they may get pregnant, or the girls don't have something to manage their menstrual cycles, and so they start skipping school, they get behind, and then get discouraged. So education becomes a key foundation to better health outcomes. I think that, I don't know if you can see to the right, there's a little boy standing in the light, and to me this sort of epitomizes the situation in much of the developing world. Is the need is tremendous, and people are often waiting for help to come. I think safe care everywhere begins with this vision that it's possible. And so we start there with the vision. We follow this with a commitment that this is something that's important to do and that we are going to be a part of. And then we put into action the commitment in our vision, and that we adapt it to the setting. What will work in this setting will be different than what will work in a different place. But all of the different approaches that are being outlined by the World Health Organization will work in any setting, whether it's a very low income setting or very high. It simply needs to be adapted to the setting. And now I would welcome any questions you have. Thank you.
Thank you, Anne. I realized this, I was looking around that there's a lot of us that have worked in healthcare in one form or fashion, and I don't think any of us worked in this environment, thankfully, except for you.
Yeah, this is where I sleep in a tent and I make sure I have really good zippers. I never want to not have good zippers because of the snakes and the scorpions and all sorts of stuff. So.
Oh, come on, guys. Second cup of coffee time.
Hey, Ann.
Hey, how you doing?
It's Lynn. I'm good. So I guess I'm one of those people that likes it simple. So how can we help? I mean, I know you mentioned, a blood drive, but how would you do? I mean, is this just an international project? You partner with a Rotary club there? Are there a lot of Rotary clubs there? I mean,
Thank you. Great question. So this presentation, I probably didn't give quite enough background. So I'm on the board of the International Rotary Fellowship of Health Professionals. And because the World Health Organization has come out with this plan, we've undertaken to get Rotary involved in this. And so World Patient Safety Day comes up in September. And so there are 5 different presentations. This one was supposed to be the first, but I suggested it be the second because the first one will actually get more into what this World Health Organization plan is. I briefly alluded to that at the beginning, to start with the vision, the principles, and then objectives, but I didn't want to get too far into that because I wanted to talk more about the low-income countries. And then there will be the session after this, we'll talk about doing the plan, study, do, action, and some other, go down through this. So the idea for all of this is that we would educate people who are intending to do in Rotary, and non-Rotarians too, that are interested in doing grants, that might be interested in learning more about this. What I would say is I got, because of my interest in international, I got involved in our Rotary grants. And from that, I found that we were getting recommendations to do grants on things that sometimes just didn't make sense. Just like sending neonatal high-tech equipment to someone that wasn't ready for that. I mean, I don't know that this hospital in South Sudan has ever used that equipment. I don't know how they could if you don't have consistent electricity, if you don't have consistent oxygen to do these things. So I wouldn't expect you to come up with an action plan out of this. I would just want to say that there are resources out there. I joined the board of the Rotary Fellowship because it was an opportunity to take my education and experiences and hopefully to put them into an area that would be helpful. There's another group that is working on equipment, so that if you have an idea that you want to send equipment somewhere, here's some criteria for how do you think about that? What are you going to send? Some organizations, I work with an organization called Project Cure, primary office out of Colorado, and they make sure that equipment is checked out, that there is a manual that goes with it, that is online accessible, so that people will, and they also have access to someone who can repair equipment. So you don't want to send things over that they don't know how to do. I'm working on sending a container to Tanzania, and I have asked for a list of things that people need there. But then before it goes over there, I'll go to this clinic and I will be the representative for Project Cure to make an on-site assessment there. One of the things that I want to know is, what equipment do you have that's being stored? Because I've heard that as much as maybe 40% of equipment that is in low-income countries may just be in storage. It may not be working. Are we dumping equipment? Are we dumping supplies over there? Are we sending things that, get a tax write-off, but they're not useful for where they're going? And then they have storage problems when they get there. So I don't know that you can make an action plan out of this, but other than to say, if people in your club decide you want to do a healthcare grant, talk to somebody that's done it, get back in touch. Depending on what kind of, setting it is, we may be able to help connect you with someone that can be helpful in that. Okay?
Thank you.
Yes. Good to see you again.
Carolyn has a question.
Okay.
Hi, Ann. Thank you for coming and presenting today. I've worked in Africa at least one time, in South Africa, so I've seen a lot of needs there too. Is there a way that you can, you have a list of organizations that work with you that Rotary could partner with, maybe select a certain area that we would like to help with? Maybe that would be a little bit easier to identify something.
Yeah, I met this wonderful physician when I was living in Alaska, and it turns out that she was the MacArthur. She wasn't whenever I met her, but she became the MacArthur Fellow in Medicine for her work in East Africa, and that was the little white hand that was giving milk to the baby. She would cringe if she knew I put her picture up. That's why I didn't. She's very shy. But yeah, that's the Sudan. There's several groups. That's Sudan Medical Relief is the name of that organization, and Jill does medical work there. I also am on the board of Alaska Health Project South Sudan, and it's a group of friends that went over to help Jill, this physician I'm speaking of, Jill Seaman, and started doing boreholes there because one of the big issues is clean water. People were drinking and bathing, and cows were doing whatever they do in the river, and that's where people were getting their water. So now we have multiple boreholes they've managed in the village, do some construction work. That's a nonprofit. Cross Currents handles the funding for Jill's project. So yes, there definitely are. There's a physician in Egypt who's also on the board who does heart procedures. So many babies are born with open heart openings between two vessels within the heart, two chambers within the heart, and will not have a normal life unless that's repaired. And she's able to do that for less than $3,000 a child. I think in the US, it'd probably be 10 times that. But, you know, that's a project that I'm involved in. Another, the one that's the container to go to Tanzania is an orthopedic surgery. And he's also on the board of the Rotary Health Professionals. And they have a project to put in an ICU and expand their orthopedic surgery program to make that a self-sustaining to support that hospital. So there are lots and lots of projects out there. I'm happy to send a link to some of these and invite you to join in. One of the things that I did over there, Jill said, but Ann, we need a school. So I started a school that now has over 1,000 students a day. And, you know, it's starting where we are, finding what's possible and just reaching out and doing. So this is what makes me feel good. This is it ruined my retirement, but, but here we are. Thank you for asking.
Thank you.